Welcome, everyone, to this nurses webinar. And of course, special thanks to our speakers of this webinar, Professor Nikki Karavitaki and Sherwin Gracino. And in this webinar, the aim is to provide a virtual educational platform to support endocrine nurses in ongoing professional development with a focus on developing nurses' knowledge and clinical skills in endocrinology. And you can see the objectives to provide an endocrine-specific training for nurses so they can develop a deeper understanding of the different disorders. And this one is about Cushing's to support endocrine nurses in understanding and utilizing the endocrine competency work in their clinical practice. And especially this is to provide a virtual platform for networking and support. All these webinars which are provided are linked to the competency framework. And currently this webinar is about Cushing's, which is competency 3 in this framework. And besides the original English version, it's also translated in French, German, Polish, and Spanish, and more translations are coming this year. This is how our webinar of today is looking. We will start in a few minutes with an overview about Cushing's disease provided by Professor Nikki Karavitaki. After that, we immediately go into Q&A. So if you do have any questions, please provide them in the Q&A box. And after the Q&A, we will go through with the talk of Sherwin, which is about dynamic function testing in Cushing's disease and the endocrine nurse competency. Yeah, I think it's time to start with the talk of Professor Nikki Karavitaki. She is a professor of endocrinology at the University of Birmingham in the UK, and she's the co-lead of the pituitary service at the University Hospital Birmingham NHS Foundation Trust, a tertiary endocrine referral center in the UK. Professor Karavitaki has published widely in the field of pituitary tumors, and is recognized internationally as an expert in pituitary disorders. It's yours, Professor.
So thank you again, Kirsten, and hello everyone, and many thanks to the organizing committee for the kind invitation. I've been asked to cover an as ever challenging topic, one of the most exciting areas in pituitary endocrinology, the Cushing syndrome, and to discuss the diagnosis and management. As you will see during my presentation, I will mainly focus on Cushing's disease, which is my main area of clinical and research interest. And of course, we will go through this journey together. So these are my conflicts of interest. And what are we going to cover in this talk today? We will discuss the causes of Cushing's generally and when to investigate for Cushing's. Then we will go to the area of how to investigate. Then we will move on to how to manage Cushing's disease, and we will end up with some conclusions. So, what is Cushing's? Of course, we all know Cushing's is too much steroids in the blood. And we have the endogenous Cushing's, where the too much cortisol comes from the adrenal glands. And we have the iatrogenic Cushing's, in which various steroids are offered through various routes, and they end up causing the classical clinical picture of Cushing's. And in terms of causes, it is divided to ACTH dependent and ACTH independent. For the ACTH dependent, the most common cause is pituitary-dependent Cushing, so Cushing's disease. This consists of 60 to 80% of endogenous Cushing's cases. We have ectopic production as well of CRH, ACTH, and the ACTH independent has to do with adrenal causes or with exogenous glucocorticoid administration. So as I mentioned, our main focus will be Cushing's disease. So the first question which can become a big problem in our clinical practice, in our daily clinics, when to investigate. We know that the Cushing's is associated with a plethora of signs and symptoms, and many of these overlap with other conditions, especially with a metabolic syndrome, or some of these are even seen in the general population who does not have Cushing syndrome. So the question is, how can we decide when to start these investigations? And this is a table from a beautiful paper published in 2019, showing the prevalence of various manifestations in Cushing syndrome and the prevalence in the general population, just to show you the extent of the problem at the very, very first steps of the diagnostic process. So recent weight gain in Cushing's, we can see it in 70 to 95% of the cases. In the general population, it can be up to 50%. Being overweight, 21 to 48%, and again, 50% in the general population. Obesity, 32 to 41%. Prevalence in the general population, 20%, and this may be rising as time passes. Hypertension in Cushing's, we may come across it in 58 to 85%, in the general population up to 44%. Abnormalities in glucose metabolism, we see the rates here, and again in the general population we have a significant number of people who have diabetes or impaired glucose tolerance. And to move on with other manifestations, dyslipidemia, it is seen in a significant number of patients with Cushing syndrome. Still, it is in 22% of the general population. And to look at other manifestations where we have less data on their prevalence in the general population, just to give you an example. Sleeping disorder or fatigue in 60% of the Cushing's patients and in up to 25% of the general population. And you may say 25% is obviously not compared with the 60%, but this 25% is for the general population. So you can imagine the absolute numbers we are talking about. So the story of starting investigating for Cushing's can be quite complicated. And Cushing's disease is rare. We gave percentages of manifestations, but Cushing's disease is rare. The prevalence is 4 to 6 cases per 100,000 people. The annual incidence 1 to 2 per million. Therefore, the pre-test probability of finding Cushing's is generally low. On the other hand, we know that even nowadays, the mean diagnostic delay is around 4 years. And importantly, in a study that was published a few years ago, it was shown that until we end up with a diagnosis, a mean of around 5 physicians were consulted, and look at the range 1 to 30. And all these translate to delays in the diagnosis, and importantly to the delays in the successful management of these patients. And as we can all imagine, this can have a negative impact on the long-term prognosis of these patients. So coming to the question when to investigate based on clinical manifestations, the Endocrine Society a few years ago had published the guidance, and this is a table in which we can see the features that best discriminate Cushing syndrome, which, however, we have to emphasize, most do not have a high sensitivity, but best discriminate. This could be easy bruising, facial plethora, proximal myopathy, or what we call proximal muscle weakness, striae, especially if they are reddish purple and they have they are wide more than 1 centimeter, and particularly in children if we have a child with weight gain and decreasing growth velocity. So these are best discriminating features. The others that are shown below are features in the general population that are common or less discriminatory. And I will focus also on some overlapping conditions like hypertension, type 2 diabetes, and vertebral osteoporosis, which would raise an alarm as to whether we need to investigate for Cushing's if their onset is at a young age. So who should be tested? Based on the guidelines, we should test patients with unusual features for age, as we said before, like osteoporosis, early onset hypertension, patients with multiple and progressive features, particularly those which are more predictive for Cushing's syndrome, children with decreasing height, velocity, and increasing weight, and patients with an adrenal incidentalloma, which is compatible, which has imaging features compatible with an adenoma. Of course, we will do these investigations if we have excluded exogenous glucocorticoid exposure. And the guidelines recommend against widespread testing for Cushing syndrome in any other patient group. And it is important to highlight that because by investigating groups which have low pretest probability for Cushing's, we are running at a high risk of getting false positive results. And obviously this will initiate further unnecessary investigations and anxiety to the patient. And of course, we have to consider the costs of unnecessary tests. And just two numbers, which I have found interesting. If we want to look at patients with type 2 diabetes mellitus, the prevalence of Cushing's in this is between 0 to 3%. And in people who have hypertension, the prevalence of Cushing's is less than 1%. Of course, we may have cases in which we are in doubt. They may not have the full manifestations or many manifestations resembling Cushing's. And in such cases, we may have a dilemma how far we should go. But again, we need to remember that because Cushing syndrome tends to progress, if we have a patient who gradually accumulates new features, this indeed increases the probability that the Cushing syndrome is present. So in these cases, it is worth waiting a little bit instead of rushing into investigations and further problems. And of course, looking at old photographs of the patient may help us understand if physical changes have happened over time. So that's about when to investigate. The second question, how to investigate? How we are going to prove that a human being has Cushing's syndrome? The first thing we need to consider is that we may have patients who have what we call physiologic hypercortisolism, or in other words, hypercortisolism which is not associated with a tumor. And such scenarios we come across in patients, in people who have obesity or diabetes mellitus, particularly poorly controlled, depression, alcohol dependence, malnutrition, physical stress, just to name a few. So if we exclude or make sure that the possibility of these conditions is very low, the initial testing would include measuring urinary free cortisol, 24-hour urine free cortisol. I would go with at least 2 collections during the variability of the cortisol secretion. Late night salivary cortisol nowadays, much less blood cortisol, late night blood cortisol, again, at least 2 samples. We have the overnight dexamethasone test. We have the low dose dexamethasone test. And as we will see later, multiple tests are usually needed to establish the diagnosis. Let's see now the sensitivity and specificity of the tests I mentioned. So this is a table from, again, a very useful paper published 3 years ago. We can see the sensitivity and specificity of the various tests. I just want to highlight that it seems that urinary free cortisol has the lowest diagnostic benefit. And then we have other tests that follow. So urinary free cortisol may not be the best test to confirm the presence of cortisol excess. And if we discuss a little bit the dexamethasone suppression test, the cutoff we are using is below 15 nanomoles per liter. We have to remember the false positive and false negative scenarios. So false positive, if we are dealing with increased cortisol binding globulin, like in patients who are on oral estrogens. False positive results can be given in any physiological or pathological condition that increases cortisol production. Some drugs that accelerate the dexamethasone metabolism can give false positive results, and of course, malabsorption of dexamethasone. And this is why nowadays we measure more and more the dexamethasone levels after the dexamethasone, especially an overnight dexamethasone suppression test, and we see if the levels were good enough to make the test valid. False negative we can see in kidney or liver failure. How about the urinary free cortisol, which is an index of circulating free cortisol? So we can come across false positive results, and this has to do with a high fluid intake, more than 5 liters per day. And obviously, when we look at the results of urinary free cortisol, we need to look at the urine volume, the creatinine. False positive may be seen again in any physiological or pathological condition that increases the cortisol production. Some drugs may lead to that. And false negative, if we are dealing with an incomplete collection or with renal impairment, or if we are dealing with a cyclical Cushing's, or even with mild Cushing's. Nowadays, where we are using more the HPLC and tandem mass spectrometry, we have to remember that the upper limits of normal are much lower than the limits that were used with antibody-based assays. How about the late night salivary cortisol, which is indeed an easily performed and non-invasive test, and the sample can remain stable at room temperature. There are some cases in which we may have false positive results, like stress immediately before the collection, or again, any pathological condition that increases the cortisol production, tobacco, consumptions of licorice, and as we can all expect in shift workers. So we have to keep this in mind when we interpret the results. And we will do our tests. There may be times that we are not sure, and we may consider re-evaluation. And which group of people this will be? This will be in individuals who had normal test results, but the signs and symptoms of those that resemble cortisol excess progress. Let's say we see our patient 6 months later. We need to reevaluate also individuals who have normal results, but we have high suspicion of cyclical Cushing's. And it is worth reevaluating individuals who had discordant results, particularly if the pre-test probability of having Cushing's was very high. And this is an algorithm that we had published in the Lancet Diabetes Endocrinology, the guidelines of Cushing's in 2021. So just to summarize, if we have suspicion for Cushing's, obviously we take out exogenous steroids. If the probability is low, we do a screening test. If this is normal, the Cushing syndrome is unlikely. If it is abnormal, we proceed with further investigations. If we feel that the probability of endogenous Cushing's is immediate or high, we do 2 to 3 screening tests. If they are abnormal, we proceed to further investigations. And if they are normal, the Cushing syndrome is unlikely, or we are dealing with a cyclical Cushing's. And once all these tests are normal, again, we can be quite confident that we are not dealing with Cushing's, or we have the cyclical Cushing's. If they're abnormal, we go to the pathway of Cushing's investigation, differential diagnosis. And if they are discrepant, as I mentioned before, we need to consider reevaluating periodically and repeat testing. And once we have confirmed Cushing's, we measure the ACTH, and in adrenal origin, it is low, whereas if it is the ACTH dependent, as we call it, it can be normal or high. And then further steps would involve to do a pituitary MRI. If we have an adenoma present, which is more than 10 millimeters, most likely this is the cause of the Cushing's. If we don't see an adenoma, or if it is small enough, below 6, the 6 to 9 is still a debate, but below 6 is more definite. We have to consider other means from differentiating between ectopic Cushing's or pituitary Cushing's, and we would consider IPSS or other tests. Nowadays, with the lack of CRH, obviously we are changing to some extent our algorithms, and this is still a matter of discussion. So we had our high index of clinical suspicion. We did our tests. We proved it is Cushing's. We proved it is ACTH-dependent Cushing's. We proved it is pituitary Cushing's. What next? Of course, we have to manage our patient. And in terms of managing the tumor and the cortisol excess, what can we have in our table for that? We can have surgery, we can have medical treatment, radiotherapy, or bilateral adrenalectomy. And let's start with the surgery. Transsphenoidal surgery is still the protagonist in managing Cushing's disease. It's the first-line therapy. And unfortunately, in 1/3 or sometimes in series up to half of the scans of the patients with Cushing's disease, we may not be able to identify a tumor. And this is where the value of an experienced surgeon adds up and defines the management and the good outcomes of the patient, as the surgeon will have to explore the pituitary gland and identify the tumor. And what is the success of surgery? What do we define as remission, first of all, after surgery? I think we need to have very clear criteria for that. And nowadays, we use the cutoff of blood cortisol below 55 nanomoles per liter. There are various post-operative protocols. In our center, for example, the patient is operated on. We don't offer steroid cover in the first post-operative days. We monitor the patient closely, clinically and biochemically with cortisol measurements every 6 hours. And once we pick up this magic number, we are happy that mission has been achieved. We have to remember, though, that there are a few cases in which we have delayed remission, and this requires monitoring until we pick up the post-operative desired cortisol nadir. Now, there are exceptions to this number. There are exceptions which have to do with patients who have cyclical Cushing's, or they have mild hypercortisolism, or they had been treated medically preoperatively. So in these cases, the normal corticotrophs have not been completely suppressed. And therefore, the patient may be in remission, but still we don't pick up the very low cortisol we want to pick up. In such cases, a way to identify remission is probably by measuring late night blood or salivary cortisol. And if we see that the diurnal rhythm is there, then this would suggest that we have the desired effect of remission. And what are the percentages of remission? So in adult series, what we have seen in the more contemporary literature and with the advances of surgery is that in microadenomas, on average, we can achieve remission in 73 to 76% of the patients. In experienced hands, we can see even higher rates. In macroadenomas, in a little bit less than half of them, achievement of remission has been reported. And factors that are associated with the achievement of this effect are the size of the tumor, definitely the cavernous sinus invasion, because if there is a significant invasion of the cavernous sinus, obviously the surgeon will not explore and operate in this area because of potential negative or even catastrophic consequences. Another factor that is associated with remission is if we have a visible adenoma on imaging, so the surgeon has a guidance on where to go, and again, the surgeon's experience. And the surgeon's experience is so important that there is indeed a recommendation nowadays, which is strong recommendation that the surgery should be performed in specialized pituitary tumor centers of excellence, be done by an experienced pituitary surgeon with a follow-up by a multidisciplinary team, and ideally, outcomes of pituitary surgery and cost effectiveness should be reported and be made publicly available. How do we monitor our patient after the surgery? Obviously, if there is remission, we offer glucocorticoid replacement until the access recovers. We need to educate the family and the patient, the family members and the patient on how to deal with adrenal insufficiency. We need to inform the patient about the glucocorticoid withdrawal syndrome. The body goes into a different state with much lower exposure to cortisol, and the body doesn't like it. And this manifests with poor appetite, fatigue, muscle pains, arthralgias, depression, anxiety, and the recovery may be 1 year or longer. And sometimes in these cases, we may have to temporarily increase the dose of glucocorticoid we are offering, but of course we need to be cautious so that we avoid iatrogenic Cushing's. We don't want the patient to go where they were before the operation. And it is very important to warn the patients about this, and even more important, to reassure them that they should not worry about this. And unfortunately, this is part of the pathway, the journey towards remission and feeling better as time passes. And the recovery may take 6 to 12 months. It may take longer in some cases. And we need to have a very robust management follow-up protocol. So what we need to do is to check the morning cortisol every 3 to 6 months of hydrocortisone. So the last hydrocortisone dose should have been given on the morning of the previous day. And once this morning cortisol is above 200 nanomoles per liter, sometimes 150 nanomoles per liter, it is time to do a short synactin test and see if the axis has recovered. And once we have established that the axis has recovered, then we need to consider assessment for recurrence of the Cushing's, see if the Cushing's is back. And speaking of recurrence, the chance is there, it's not low, and in various series, this has been reported between 5 to 35%, depending on the length of follow-up, and also depending on how remission of the Cushing's had been defined. Half of the recurrences apparently are diagnosed within the first 5 years, but lifelong monitoring is required because recurrences can happen even after 5 years. I've seen a recurrence even 15 years later when no one was expecting that. So lifelong monitoring is needed. There are various factors which have been proposed that could be associated with a recurrence of the Cushing's. Amongst them, I think one which stands more and more is the early recovery of the hypothalamus-pituitary adrenal axis. So if we have a patient who was not on medical treatment before the surgery, and the patient also did not have cyclical Cushing's and is operated on, and we achieve remission, and then 1 or 2 months later the axis has recovered, this can be a sign that remission may come to this patient, and we have to be careful. And how do we diagnose recurrence? As I mentioned, we need to do the test after the recovery of the hypothalamus-pituitary adrenal axis, and we have obviously stopped the hydrocortisone, the steroids that the patient is on, and then we do this assessment regularly thereafter. And what tests could we use? We could use late-night salivary cortisol, 24-hour urine-free cortisol, or dexamethasone suppression test. The desmopressin test is also discussed. It seems that the late-night salivary cortisol has the highest sensitivity and specificity in picking up recurrence. We need serial tests, though, due to the wide variability of the results. And so the late night salivary cortisol is abnormal earlier even than the dexamethasone suppression test of the urinary free cortisol. The 1 milligram dexamethasone suppression test, it's likely to be abnormal before we see high 24-hour urine free cortisol. And then the 24-hour urine free cortisol is a direct reflection of the bioavailable cortisol, is the last test to show abnormal results. And in some centers, they use desmopressin test. It has been proposed that this test can predict the presence of corticotroph tumor And of course, it's dynamic and labor-intensive testing. But giving a message, late-night salivary cortisol, first abnormal, followed by 1 milligram dexamethasone suppression test. And if we have to deal with persistent, Cushing's not in remission, or recurrent Cushing's, how are we going to manage our patient? Again, we have various management options, like doing repeat surgery, offering medical treatment, offering radiotherapy, or going towards bilateral adrenalectomy. And here, the approach is individualized, and we need a multidisciplinary team discussion and decide for each patient individually based on their needs, also on their wishes, on the availability of various management options in each center. So there is not just one way, one solution. If we go for repeat surgery, what are the indications? Obviously, if we want to go for that, we need to make sure that there are no contraindications for an operation. It is also indicated if there is evidence of incomplete resection of the tumor, or we see a pituitary lesion on imaging. If the imaging is negative and we are dealing with persistent disease, before we proceed to anything further, we need to step back and ask ourselves, did this patient have Cushing's of pituitary origin? There is not a point going back to the pituitary when we are not sure that this was Cushing's disease. So the help for that, the answer for that, can be given by a previous positive pathology showing that was indeed a corticotroph tumor there, or by a positive inferior petrosal sinus sampling. And following repeat surgery, the remission rates range between 37 to 88%, again, depending on the criteria used and how long the patients had been monitored for. And as probably expected, there is a higher risk of endocrine and surgical complications. And again, I emphasize the importance of an experienced surgeon, particularly if this area has been explored surgically before. Let's move on now to the medical treatment. When shall we use medical treatment? In persistent or recurrent disease, and also in patients who are not good candidates or they refuse surgery for primary or recurrent Cushing's. And it is also used as a bridge treatment after radiotherapy. So the patient has active Cushing's disease, we irradiate their pituitary, we wait until the result comes, and during this interval, we offer medical treatment to the patient so that they are not exposed to the cortisol excess. We have many drugs, as we will see in the next couple of slides, and the selection of drug depends on many factors. It depends on the mode and rapidity of the action of this medication, on the side effects profile, how long we are going to offer this treatment, is this medication available locally, and of course the cost. Is it a very expensive medication, and whether there is something cheaper drug-wise that we can offer this patient and achieve the same results. So let's go through some medical treatment options. We have the ketoconazole. This is an adrenal steroidogenesis inhibitor. Various retrospective studies suggest that around 65% of the patients achieve normal 24-hour urine-free cortisol. There is up to 25% escape. Side effects, the gastrointestinal disturbances, what we all know, the increased liver enzymes, the gynecomastia, and particularly for the liver enzymes, we have to be cautious and monitor the patients. And there is also decrease in testosterone, and that's why this treatment would be preferred in women, because the men will need follow-up for development of hypogonadism. Osilotrostat is the relatively new kid on the block, is a very potent adrenal steroidogenesis inhibitor. Various studies have come up. A phase 3 randomized withdrawal study showed that 24-hour urine-free cortisol was normalized in 86% of the patients. Side effect, it leads to increased androgenic and mineralocorticoid precursors. So we may come across hirsutism, hypertension, hypokalemia, and given that it is very potent, we can also lead to adrenal insufficiency. And we have to bear in mind that if we are using assays which measure the cortisol, immunoassays, which measure the cortisol, the 11-deoxycortisol, which increases as a result of this treatment, can cross-react and give us high results of cortisol when we monitor the response to treatment. And obviously, it's worth doing careful monitoring for androgen excess in women. Other adrenal steroidogenesis inhibitors, the metyrapone, which is used widely in the UK. Again, retrospective studies have shown urinary free cortisol normalization in around 70%. Again, as with the osilodrostat, we have increased androgenic and mineralocorticoid precursors, so similar key considerations. Mitotaine is used mainly in adrenal cancer, so we will not go with this treatment in Cushing's disease. And we have the etomidate, the drug which is used in anesthesia. It can reduce the cortisol. It is, in retrospective studies, we have approximately 100% serum cortisol control. It can be used to sedation or anesthesia, adrenal insufficiency. As you can imagine, it is off-label use only. It causes very rapid reduction in the cortisol, and we would use it in acute treatment of truly severe hypercortisolism. And in these cases, because of the high efficacy of the drug, we will require to give hydrocortisone intravenous at high doses to avoid adrenal insufficiency. Levoketoconazole is also described as another new drug. And another family is the somatostatin receptor ligands. We have the pasireotide, for which various studies have shown, especially for the long-acting release, 40% normalization of the urinary free cortisol, mainly in less severe Cushing's. The side effect we are all aware of are the abnormalities in the glucose metabolism. And a key consideration is that it can decrease tumor volume. So that's something we take into account. And another medication, the dopamine receptor agonist. So we have data on cabergoline, in which retrospective studies again have shown normalization of the urinary free cortisol in around 40%, but a number of them escape later. We need to remember the side effects of cabergoline as dopamine agonist that we use in prolactinomas as well. It is off-label use only for Cushing's disease. It can reduce the tumor volume. So again, another point worth remembering. And as I mentioned before, we have the potential side effects of cabergoline regarding the impulse control disorder or risk of cardiac valvulopathy. This is unclear in this particular group of patients, but it is a reported side effect. So another family is the glucocorticoid receptor blocker, mifepristone. There have been studies which show that there is significant improvement in glycemia in approximately 60% of the patients. Because it is a receptor blocker, we cannot use the cortisol marker as a marker for efficacy. So we go with clinical and laboratory data in these patients. And there is a risk of hypokalemia and adrenal insufficiency, and obviously the patients require close monitoring. So that was about the medical treatment. And if we would like to think which drug we are going to use when, the approach would be, if we want a rapid normalization of the cortisol, better use adrenal steroidogenesis inhibitor, example, metyrapone, osilodrostat, or in extreme cases, etomidate. If we have mild disease with residual tumor and potential for tumor shrinkage, we could consider pasireotide, cabergoline, and of course, keeping in mind the potential side effects. And in pregnant women or those who are keen for pregnancy, cabergoline or metyrapone could be considered, but we have to bear in mind that they are not approved for use in pregnancy. Just 2 words on the block and replace regime. So we offer a high dose of metyrapone or ketoconazole, and at the top of this we add replacement doses with hydrocortisone usually. This can be used in severe disease, this can be used in cyclical Cushing's, or in patients who are poor candidates for surgery. So that's about the medical treatment. Now let's move on to radiotherapy. Radiotherapy is kept for persistent or recurrent disease, or if surgery is not an option, or for aggressive tumor growth. And what are the outcomes of radiotherapy? These are data from 2 studies looking at conventional or fractionated stereotactic radiotherapy, variable criteria for defining remission. I will go to the Miniti paper, which showed that at 5 years, 78% of the patients had achieved remission. Tumor control data are very, very optimal, and the average timing to remission is around 2 years, and we use this number to inform our patients in clinic. And if we want to look at specifically to the SRS, which is more and more used nowadays, these are data from a number of series. So we have variable follow-up periods, median dose 23 gray, tumor control, really good data, biochemical remission. Again, we have variable rates, but overall, they seem to be more than 50% for the follow-up period that is reported. And again, the timing to remission is usually 14 to 26 months. So as a rule of thumb, around 2 years. How do we monitor the patients after radiotherapy biochemically? We measure 24-hour urine-free cortisol after stopping any medication that lowers the cortisol at 6 to 12 monthly intervals. And we monitor also if the patient develops manifestations of adrenal insufficiency whilst they are on medical treatment. And as we all know, we need to monitor for the late radiotherapy toxicities. And again, we need to remember that even if we irradiated the patient, recurrence is still possible. We should never forget about this remote possibility so that it doesn't escape if it ever happens. And the final management option is bilateral adrenalectomy. It can be used as a life-preserving emergency treatment in very severe Cushing's, which cannot be quickly controlled with drugs, or after failure of other treatment options. And we have all heard about the risk of Nelson syndrome, so expansion or progression, as it is called nowadays, of the corticotroph tumor. The prevalence rates depend in the literature, depend on the diagnostic criteria and how long the patient has been monitored for. It ranges between 0 to 60%. And what are factors that will make us think, predict that the patient will develop Nelson's after the bilateral adrenalectomy? The most consistently reported are visible corticotroph tumor after the bilateral adrenalectomy. And more importantly, if the ACTH is high in the first year after adrenalectomy, this can be a sign that probably the patient will show corticotroph tumor progression. So how do we monitor these patients? These are the guidelines we had produced a couple of years ago. So obviously surveillance by imaging after 3 months, and then every 12 months for the first 3 years. After that, the imaging interval may increase, but again, in high-risk patients, closer surveillance might be required, and this involves the imaging. Obviously, clinical and biochemical imaging is also necessary for these patients. And once Nelson's develops, how shall we manage this? We had done a multi-center UK study in which we looked at the outcomes of these patients, and it was clearly shown that if we offer active treatment with surgery, combined or not with radiotherapy, we achieve better results, better tumor control. And another important point from that study was that the complexity of the previous treatments for the Cushing's before they developed Nelson's predicted how the Nelson's would do. And maybe the complexity of these treatments reflected the aggressiveness of the tumor. And that's why, from the very first beginning, and that's why when Nelson's developed, things did not go to the right direction. So that's about management. A couple of slides on mortality and comorbidities. We all know that Cushing's kills. It's something that it is widely known, and these are data from studies of the last 10 years, which show the standardized mortality ratios of these patients. And in red are those which show high standardized mortality ratios. An example, a study that came from Birmingham actually showed that in patients who have persistent or recurrent disease, the mortality is 4 times higher than that of the general population. When I was in Oxford, we had published a study from the data there, and we showed really high standardized mortality ratios, even in patients in remission. Same was from a beautiful study from Sweden a couple of years ago. So unfortunately, even in patients who are in remission, we will see high mortality. And if we look particularly at cardiovascular mortality, again, this features highly in these patients. And even in patients who are in remission, the cardiovascular mortality is high. And these are lessons we have to take on how we manage these patients, because it has been clearly shown that the presence of diabetes and hypertension in some studies in patients with Cushing's are predictive factors for high mortality, which means that we have to attack these risk factors. And speaking of morbidities, what happens in the long term about comorbidities after remission of the Cushing's? It is unfortunately well known that even after successful treatment, a number of complications and risks may persist, and this raises concerns on the long-term prognosis of the patients. So metabolic and cardiovascular comorbidities persist, like excess weight, like hypertension, like diabetes, like dyslipidemia, and may persist even, as I said before, after successful management of the Cushing's, leading to the high cardiovascular mortality. And in a study we had done many years ago, published in the Lancet Diabetes Endocrinology, a collaborative study, it had been shown that even patients who have been in remission for a minimum of 10 years, even in these patients, the cardiovascular mortality remained high, around 3 times higher than that of the general population. So the recommendations nowadays are that we need to evaluate, to monitor and treat according to current guidelines the patients at high risk of cardiovascular disease, and this will be in collaboration with primary care or other specialists. So management of Cushing's is not just achieving nice cortisol levels, but looking at the comorbidities. How about bones? Osteopenia at diagnosis in up to 78% of the patients, osteoporosis in 22 to 57%. And in the majority of the patients, we see improvement of the bone mineral density within 2 years with no specific treatment. But we need to make sure that the patient has appropriate calcium and vitamin D intake and appropriate hormonal replacement. Not too much hydrocortisone replacement, steroid replacement, and of course, appropriate gonadal hormonal replacement if it is needed. And finally, neurocognitive and psychological effects. Unfortunately, the literature and the experience shows that cognitive deficits and neuropsychiatric symptoms improve after remission, but they remain impaired compared to the healthy controls. And depressive symptoms may persist even long after remission. So we need to pay special and continuous attention for these aspects, aiming to improve and possibly normalize the quality of life for patients who had Cushing's. So in conclusion, Cushing's disease and generally Cushing syndrome, but today we are talking about Cushing's disease, remains a challenging condition to diagnose and manage. Surgery remains the first line of treatment unless this is contraindicated. We need experienced surgeon and we need care to be offered in pituitary centers of excellence. Thankfully, nowadays, we have many treatment options available for persistent or recurrent disease or in poor surgical candidates, and an individualized approach with a multidisciplinary team involvement is necessary. And we shouldn't forget the management of Cushing's related morbidities. And again, by doing that, we are improving the long-term outcome of our patient and our survival. And I will finish with a phrase which I keep saying to me every time I see a new patient with Cushing's, just to show how challenging and at the same time how fascinating this condition can be. So the endocrinologist who says that he or she knows about Cushing's has not seen many Cushing's. And with this, I would like to finish and to thank you very much for your attention. Thank you.
Thank you so much, Professor Karaviataki. At this moment, there's some time to answer some questions, and I've got one or two already seen. One of the questions was, would you routinely prescribe thromboprophylactic treatment to patients with active Cushing while waiting for the definite treatments?
Yes, nowadays in our center, we nearly routinely prescribe thromboprophylaxis unless we are dealing with a patient who has very, very mild Cushing's and we are not absolutely certain that it is still indeed the case. But generally, we tend to prescribe thromboprophylaxis practically routinely.
Thank you. One question coming in from Anna. Great talk for those patients who relapse of Cushing's syndrome years after being operated of CD, but we do not have access to the pathology report or IPSS was not performed. Which is the reliability of performing an IPSS in these cases, long time after pituitary surgery? Is IPSS as good as identifying the origin of the ACTH independency as when the test is performed prior to any pituitary surgery?
Okay, if we perform an IPSS in a pituitary gland which had already surgical intervention, obviously this is more challenging. If need be, it has to be done. We don't have at least to my knowledge, series which give us guidance on IPSS in previously operated on pituitaries, at least I'm not aware of. It is definitely more challenging, but if it has to be done, it has to be done. It will be done. If we don't have pathology report, and we will not be in the position to have a pathology report, my question would be if post-operatively the patient at that time, after the first operation, had undetectable cortisol and how the cortisol evolved after that. That would be another guidance for me.
Talking about IPSS, I was curious, with not being CRH available, what's your preferred in the diagnostic process?
Yes, well, now with the lack of CRH, we are in sort of trouble. In our center, we have already implemented IPSS with DDAVP, and we use the same diagnostic criteria.
I think one more question. Are you able to support patient psychology in your center with managing their condition? Or how do you provide psychology?
This is a question which makes me feel quite sad because even until now, it has been difficult to identify a service, a psychology service that would be able to help these patients. And this is a battle we are giving for quite a while now. Unfortunately, there is no dedicated psychologist, and probably in no center there is a dedicated psychologist for patients with pituitary conditions generally. It's a battle we have to win because this is a service and a part of care that these patients really need.
Absolutely. Professor Karaviataki, thank you so much for this excellent talk. And we are moving on to the second speaker of our session, which will be Sherwin Christino. And Sherwin is a nurse consultant in endocrinology and the current chair of the European Society of Endocrinology Nurse Committee. Sherwin, it's yours.
Thank you for that, Professor Karvitaki. That's excellent talk. And really just to complement Nikki's presentation and to focus mainly on the competency, particularly for nurses, but this applies as well for anyone who's joining us in this virtual session. And to complement that, and let's look at how we're going to be applying the knowledge that we've gained from Nikki's presentation. This is my conflict of interest. As most nurses are involved in dynamic function tests, I'll be concentrating on the dynamic function tests involved in Cushing's, particularly those that are mentioned by Professor Karvitaki. However, I've only got 15 minutes, so I will be picking the most commonly used dynamic function tests, and we're going to dip slightly deeper into those tests just to understand the physiology. The most important thing for us nurses really is to understand how that test works, so that we'll be able to explain clearly to patients why they are having that test. Now, I'll present the case, and then following that, we identify the dynamic function test needed for that patient, and let's link that to the competency framework for nurses, particularly on Cushing's. So this is a 35-year-old female. She presented to GP with a 4-year history of weight gain and lack of period, depression, and acne. She was commenced on a estrogen pill called Dianet in order to regulate the menses, but there was no effect at all. And when she first attended the clinic consultation, she got a raised BMI of 41. She's got a facial plethora. She's got abdominal stretch mark, and she's got muscle weakness, proximal muscle weakness. And this is the patient. And when she attended the clinic, she showed us this picture, and she consented for this picture to be showed to our different meetings. So this is around 5 to 7 years before her diagnosis, and this is around the time when she was diagnosed. So showing us the weight gain that so the weight that she gained over the years. Now, Professor Karvitaki mentioned the challenge in us diagnosing Cushing, that we cannot rely on one single test. And because it's a very difficult disease to diagnose, we have to make sure that we have all, we are convinced that we got the right diagnosis. And particularly with Cushing, we cannot rely on a unstimulated or basal cortisol to identify that the patient has cortisol excess. We need to do their stimulation or suppression test to be able to identify whether the patient is producing or underproducing or overproducing cortisol. However, as Professor Karvitaki mentioned, not all tests, or there's not a single test with 100% sensitivity and 100% specificity. So the specificity and sensitivity of different tests are variable. So we cannot rely on one single test to identify this very challenging disease. So I'm going to summarize Professor Karvitaki's session in terms of how Professor Karvitaki systematically showed the diagnostic step. So the first step in Cushing, and again, I'm simplifying this for the sake of time, is to confirm whether the patient has cortisol excess. Thus, our patient who present to us with high clinical suspicion of Cushing, does that clinical feature actually relate to patient having excess cortisol? The second step is once we establish that the patient got high cortisol, is that high cortisol driven by ACTH, or is it not driven by ACTH, or is it independent of ACTH? And once we establish that, we need to know if it is an ACTH dependent, is it coming from the pituitary or is it coming from somewhere else? Now let's look at the first step. Professor Karvitaki has mentioned the different tests, overnight dexamethasone suppression test, and I'm sure most nurses here are aware on how to do overnight dexamethasone suppression test. We give 1 milligram of dexamethasone to patient. And how does this work? So let's look at the negative feedback. So we are familiar with the negative feedback of relating to cortisol production. So we know that the CRH stimulates the anterior pituitary gland to stimulate to release ACTH, and the ACTH then stimulates the adrenal gland to produce cortisol. And that then exerts a negative feedback where when we have enough cortisol, there will be less stimulation of the hypothalamus and therefore less release of CRH, and less stimulation of anterior pituitary gland if there's less CRH, and therefore there's less release of ACTH, and there will be less release of cortisol. So what do we do in overnight dexamethasone suppression tests? When we give a supraphysiologic dose of steroids, such as dexamethasone, meaning high dose of steroid, that negative feedback will kick in. So the hypothalamus will sense there is high concentration of glucocorticoid. I don't need to release much CRH, and therefore there will be less stimulation of the pituitary gland. There will be less release of ACTH, and therefore there will be very low cortisol. And in normal individual, in majority of normal individual, if we give them 1 milligram of dexamethasone, which is supraphysiologic, the following morning, after taking the dexamethasone between 10 or 12 o'clock in the evening the day before, when you check the cortisol level the following morning between 8 and 10 o'clock, the cortisol will be suppressed at around less than 50 nanomoles per liter. That is a normal physiologic response. However, if your patient's got a tumor, either pituitary tumor, ectopic tumor, or adrenal tumor that all stimulate or cause high cortisol level, the administration of supraphysiologic loaded dexamethasone will not have an effect on the cortisol level of the patient. This tumor works independently. They don't respond to that negative feedback. So they will continue to produce cortisol. And therefore, when you check, even if you give dexamethasone the night before and you check the cortisol the following morning, the cortisol will still be high, and the cutoff is usually above 50%. And that will confirm that the patient is likely overproducing cortisol. And again, the sensitivity of this, as presented by Dr. Kadapitaki, is about 95%, with specificity around 99%. However, we cannot rely on just one test. We need to do other tests. And Professor Kadapitaki mentioned about the urinary free cortisol. And again, for nurses, just a few points regarding urinary free cortisol. Professor Kadapitaki have shown you the different factors that can affect the measurement of the urinary free cortisol. Therefore, appropriate and accurate urine collection is very, very important. So this is what I want to emphasize to nurses. We need to give patients accurate advice on how to collect. At what point do they need to stop collection? So remember that the first void in the morning need to be discarded because those are the urine accumulated by the patients overnight from the previous day. So that has to be discarded. Specific timing. So we need to give clearly to patient what time do they need to collect the urine from the second void until the first void the following morning. Check if the patients are on any medication that can potentially affect the cortisol measurement from the urine. Advise the patient to drink normally and not overdo the drinking. And again, as mentioned earlier, we usually do 2 collections, 2 24-hour urine collection in order to validate. Even if you've given your patient instruction in clinic, it is also worthwhile to give them written instruction. Because remember, we give patients so much information in clinic, especially if this is a new patient. They being investigated for possible Cushing. So they will forget almost majority of the things that you discuss in clinic. So it's good for you to give them a clear instruction so that when they get back home, they can refresh themselves and their mind regarding how to do the urine collection properly. Okay, so for these particular patients, the urinary cortisol came back 612 nanomoles per liter, and the normal cutoff for us in our organization is 100 to 379 nanomoles per liter, clearly showing that it's got cortisol excess together with the overnight dexamethasone suppression test. Again, another choice that Professor Kadapitaki mentioned is about the late night salivary cortisol, and we did 2 late night salivary cortisol for this patient that both came back high as well. The second step is ACT. Once we establish that the patients indeed have cortisol excess, we now need to know which one is driving that cortisol excess. Is it the ACTH stimulation of the adrenal gland, or is it independent of the ACTH? And that can simply be done by measuring your ACTH level. And for these patients, the ACTH came back quite high, above the normal range of 70 nanograms per liter. So the third step now is we know that the patient got cortisol excess. We know it is driven by ACTH. We need to know, is the ACTH coming from the pituitary gland, from a tumor from the pituitary gland, or is it a tumor somewhere else in the body? And unfortunately, we don't have CRH now, and we have a challenge in doing the CRH. But because this is one of the mainstream tests that we've been doing, I just want to explain the physiology and how the CRH actually works. Okay, so if we got a patient with a pituitary tumor, and you give an exogenous CRH, and usually the dose is 100 microgram given intravenously. On patients with pituitary tumor, this tumor will respond exaggeratedly to CRH stimulation. It is normal for the pituitary gland to respond to exogenous CRH, but not exaggeratedly. So meaning there will be a massive response to that exogenous CRH stimulation. And what we're looking at in the CRH is that dynamic response. That's why this is called dynamic stimulation test or dynamic function test. And the dynamic response on patients with pituitary Cushing is following administration of the CRH, the ACTH will rise significantly to around 40 to 50% from baseline. And there is a dynamic and corresponding rise in the cortisol of around 14 to 20%. The specificity is around 88 to 100%, and sensitivity is about 93%. But take note, as mentioned earlier, that there's no single test that is 100% accurate. For CRH test, 7 to 14% of patients with pituitary Cushing will still fail the CRH test. Okay, now, if we're going to look at these particular patients, this is the CRH test of the patient. So let's look at whether was there a dynamic response. So the baseline ACTH was 24.5 and the baseline cortisol is 629. So was there a dynamic response following CRH administration? Meaning, did the ACTH increase by at least 40 to 50% following CRH at any time points? And we can see it almost doubled from 24 to 46. And was there a corresponding increase in the cortisol level or around 20%? Yes, the cortisol level also increased significantly from 629 to 928. So this confirms, if we're going to look at and summarize all the investigation we've done to these patients, the first step is to confirm, has this patient got a cortisol excess? We've done 3 different tests, and all those tests confirm that the patient is overproducing cortisol. The second is, was it driven by ACTH or not? We check the ACTH, and the ACTH is above the normal range. And we now confirm that this ACTH-dependent cortisol excess. The third step is it coming from the pituitary or is it ectopic? And again, there are different tests that we can do. A CRH is one of them, and IPSS is another test, which we don't have time to discuss in this session. The CRH itself shows a good dynamic response, confirming that the patient has an ACTH-dependent pituitary Cushing's. And to confirm that further, the patient has a pituitary MRI, and that confirms that pituitary lesion to your patient. Professor Karvataki has shown you this algorithm in terms of diagnosing Cushing, and I'm not going to go through that. And really just to tie that up into the competency framework, because this is what this session is all about. So in the first session that we had in April, we talked about steroid replacement, and this one is about Cushing's. And also dynamic function tests. So competency framework number 3 is about Cushing. The session that you had today, both from Professor Karvataki and from me, will give you evidence to prove to your manager or to your line manager or to your supervisor that A, you have an understanding of the pathophysiology and the normal hypothalamic pituitary axis related to Cushing's disease. Hopefully, this session able to give you an ability and some knowledge to recognize some of the signs and presentations of Cushing's and disease. And hopefully, we've given you some bit of knowledge in understanding the different types of investigation required to diagnose Cushing's syndrome and Cushing's disease. And in terms of the dynamic function test, I've given you 3 examples: overnight dexamethasone suppression test, salivary cortisol, and also the CRH test that give you basic understanding regarding dynamic function tests related to Cushing's. It is not enough for you to attend this session. For you to be able to prove that you are competent in the skills pertinent to Cushing's, managing patients with Cushing's disease, and also in dynamic function tests, it is important that you build your portfolio to prove that you achieve the competencies outlined in the competency framework. So how can you build your portfolio? After today, I hope that you can spend 5 minutes to do a simple reflective journal. And you don't need any fancy journal. You can have a simple framework in doing your journal. This is from the UK, from the Nursing and Midwifery Council, where we simply ask people who attend or nurses who attend education session like this to write, what did you learn? What was the nature of this event? This is about Cushing's disease. What did you learn from today? And summarize what you've learned from Professor Carvetaki's session and from my session. And how did the session today change your practice? You can also include, how did it change you as a practitioner as well? Did it make you more informed in terms, or more skillful in explaining the test to the patient, or counseling the patients? So this is an evidence that you can use in your portfolio to prove that you are meeting the level of competency required for this particular competence, which is Cushing's. You can also, when you're doing a dynamic function test on your counseling patient or seeing patient in clinic, you can ask either a patient or your colleague to write a testimony. How well did you do in doing that test? How well did you do in counseling the patients in your clinic? In some organizations, for example, in Birmingham, we have a competency document. If the nurse would like to do CRH tests on their own, they need to observe experienced practitioner to do that first, and then they will be assessed by an experienced practitioner in doing it independently. And they have a document that they can use to prove that they achieve that level of competence. So these are just examples on how you need to be using the competency framework. Our webinar will give you the background knowledge and the information regarding the disease, and hopefully some guide on how you can start developing your competency document and your portfolio. Thank you very much.
Thank you, Sherwin. And waiting for any questions. Well, I do have a question myself. Do you think the competency framework is only usable for nurses who are starting becoming an endocrine nurse, or do you think it's also usable when you're already an expert nurse?
Very good question, Christine. The competency framework is actually designed for nurses across the whole spectrum. So if we're going to look at the current version, it is sectioned into competent, proficient, and expert. So the competent and proficient are for nurses who are starting in endocrinology. And if you're brand new, focus on the competent area. So those spell out the different criteria that you need to achieve to call yourself as competent in that particular disease area. And then once you are competent, then you progress to becoming a proficient. And that proficient level tells you what other things you need to add in terms of your skill base and in terms of your knowledge base. And then for those who are experienced practitioner, your goal is to become an expert. And that expert part is for nurses who are experienced in endocrinology. And there's always room for us to learn and for us to develop. There will be a new version. And I can see that some of our colleagues from the UK and some of the authors are here. And there will be a new version that will be launched hopefully next year, where it will also be applicable for support worker like nursing assistants, and there is a section for that for nursing assistants, and which hopefully will be welcomed by majority of you, because I'm sure some of you are employing nursing assistant to support the endocrine clinic.
Thank you, Sharon. Absolutely agree. There are no questions. There's one question. Helen is asking, do we need to consider for OND other medications like OCP and steroid inhalers, which might interfere with interpretation? Sherwin?
Sorry, I'm just trying to figure OND, you mean overnight dexamethasone?
Overnight, yeah.
Okay, sorry.
Dexamethasone,
so I'm just trying to.
Yeah.
Okay. I think, Nikki, we don't normally advise patients to stop oral contraceptive pill. Would you, Nikki?
Sorry, is the question stopping oral contraceptive pill before overnight dexamethasone?
Overnight dexamethasone, yes.
Yes.
Yeah.
Yes, because if it is oral estrogens, yeah, because this will increase the cortisol binding globulin, and they will lead to a false positive overnight dexamethasone suppression test. It's the same like the Schwarzenegger. Any cortisol measurement, total cortisol, can be affected by medications which increase the cortisol binding globulin.
Yeah, but this only applies, Nikki, right, for estrogen-containing oral.
Yes, correct.
Pill.
Correct.
Yeah? Yes.
Correct.
So yeah, and just to highlight that, Helen, yeah. So yes, we have to stop it, but need to make sure it's for estrogen-containing contraceptive pill, because not all contraceptive pill contains estrogen. Some are just progesterone, and for topical preparation, we don't stop them. Only oral estrogen-containing.
Thank you so much, Sherwin. I don't see any other questions coming in. And because of the time, I will proceed this webinar. So thank you so much, Sherwin, for sharing this with us and giving us a really clear view how to use the competency framework. So this was the second nurses webinar, and there will be one more this year, and this will be on the 29th of November of this year about acromegaly. The ECE nurse membership provides nurses with an access to a network of colleagues working across Europe. And as a nurse, you can share your expertise on the members platform, but membership can also provide in professional and personal development. As mentioned before, as a member, you have the access to a network which can be used, have more experienced nurses be mentors and set up collaboration between different countries or even different experts or new nurses all over Europe. As a nurse committee, they provide training like these webinars, but also stimulate to do research, for example, by submitting the nursing abstracts for the ECE. These are the current membership fees for nurses, but for the ones look on the website of the ECE. Of the ESE, I'm sorry. And also on the ECE 2024, there will be a nursing program as well. And as briefly mentioned just a few seconds ago, don't forget to submit your nursing abstract, which always is really nice to see a lot of nursing abstracts on the ECE, and to see a lot of nurses there as well. I think we're almost finished. Please do not forget to submit your feedback, and thank you so much for attending this ECE ESE nursing webinar.